Sometimes I wish my wife was here to hear that. She may develop a new respect for me. Just setting myself the timer so I don't go over time.
It's not a bad idea.
There is no clock in the room, I did realize that. So it is a privilege to be here, and I thank the organizers for inviting me to present here in this Congress. And I appreciate the chairman for taking the time to chair the session. The topic is there any IVF stimulation protocol? That's how I would put it, for women with undetectable AMH, because that was the task that was given to me, AMH less than 0.1. That is a shifting target. Is there any value to using AMH in predicting poor ovarian response? Are the criteria that have been set out by the Bologna Criteria Convention worthy of consideration? And then we'll talk about the COH protocols for poor responders that have been published so far, and is there any evidence out there that any of them are worth utilizing in our patients who are desperate with undetectable AMH? And finally, adjuvants that may be of benefit. I do realize that two of my co-speakers have topics that are entirely devoted to that subject, so I'm going to literally allude to them and not go in great detail. And finally, are there any future directions? Is there any hope? So Shelik et al. Published recently on their analysis of 139 patients undergoing ICSI and embryo transfer cycles with FSH that was greater than 9, essentially high FSH in the baseline. And when they tried to produce receiver operating curves to detect any sensitivity in these tests, for cycle cancellation with the AMH cutoff level of 1.2 nanograms per mil or less, the sensitivity was 97%, which is very encouraging. But if you look at the specificity, it is depressingly low at 31%, which means you will be lumping a whole lot of other women who have perfectly normal ovarian reserve into the category of possible cycle cancellation patients. And reversing the question, if you ask, is there a way to look at the AMH levels and be assured that you will at least retrieve 4 or more oocytes? It's even more depressing. At a cutoff level, which is the best they could get using the ROC curves, of of 1 nanograms per ml, the sensitivity was very low at 58%, although the specificity at 95% may seem high, is actually pretty low. You do want to have specificities that are in the 98, 99% ranges. And finally, at least, is there any hope on using the AMH to predict ongoing pregnancies? At a cutoff level of 1 nanograms per ml, the sensitivity was a mere 83%, and the specificity was depressingly low at 82% as well. So really, it is helpful, but is there any particular level that will tell you that a patient is not going to respond? The ESHRE workshop that was published very recently concluded that the limited data on AMH and natural fertility is true, and the linear relationship between AMH and oocyte, even though they are possibly useful in predicting poor responders, it is not appropriate at present to withhold treatment in patients purely based on AMH. Now, is there anything else that might be of value apart from AMH? So Mutlu published last year their analysis of 192 patients. 49 of them were poor responders. You know, I sometimes go to work and think, oh my God, why do I have this patient population? I look at this and say, wow, my patient population is much better than that. 1 in 4 patients being poor responders must be pretty depressing indeed. So they define cancer cycle as 2 or less follicles or 4 or less oocytes retrieved. And the best predictor was actually antral follicle count in their analysis. followed closely by AMH levels and FSH levels. Perhaps what we ought to do is come up with a computerized algorithm that'll put in all these values and tell us what the chances for the patient are in terms of responding to COH. So how about the criteria for predicting poor ovarian response, or criteria for saying that a patient has poor ovarian response? This is the Bologna Criteria from 2011. Yes, it is a credible exercise, and yes, from a research perspective, at least we may have papers coming out now following these criteria, and so we'll have a little bit more uniformity. But what uniformity? If you look at the first criteria, advanced maternal age of greater than or equal to 40 years, or any other risk factor for POR. Straight away, that opens the door to a lot of patient populations. The next criteria, previous POR less than 3 oocytes, in my opinion, is probably the most stringent, followed by an abnormal ovarian reserve test, which can be anywhere from AFC of 5 to 7, bit of fudginess there, and then AMH of 0.5 to 1.1. Is it that they designed it to be so fudgy? No. It just reflects the fact that the patient populations vary. No one particular level is useful. And so to pin all the patient's hope on just one test would not do them justice. So with that, let me look at the live birth rates in Bologna poor responders. The live birth rates in Bologna poor responders by that criteria, as analyzed by Polizos from Belgium, was 485 patients with 823 cycles, and they roughly divided them into 40 years and younger or older, and there's roughly equal number of patients in both arms, and their per cycle live birth rate was anywhere from 7.1 versus 5.2% with treatment. And the same thing goes for per patient is 11.6 to 8.8%. So even though we call them poor responders, they do have quite a bit of possibility of having a live birth at the end of it. So that's something to bear in mind. And the same goes for another study from Samigliana, 108 women, 4.5% live birth rate. So that's a good number to tell, because later on I'll allude to the fact 0 to 14% is probably a good number to give of patients whose investigation turned out to be less than optimal. So what protocols are out there that are being trialed and tested and give us some guidance on what to follow in these patients? This latest study from Sankara and co-workers from London is probably the best I've come across in a long while. It is a randomized controlled trial. It took them 5 years to do this trial. They randomized the patients. Obviously, they didn't use the Bologna criteria, but they randomized the patients into 3 arms, either a long protocol, microdose flare protocol, or antagonist protocol. They had 37 patients in each arm, and they received maximum dose of FSH. And the primary outcome was 4.4 oocytes versus 2.7 versus 3.3, not statistically different. And embryos transferred in all was roughly about 1.6. Again, no different. Ongoing pregnancy rate was 8, 8, and 16, which at the outset, although it looks like that's a difference, they admit that it is not statistically significant because the study was not powered to detect a difference there. And other studies conclude the same. So here's a meta-analysis that was published by Xiao et al. 12 studies published between 2001 and 2013 were studied, and only 4 studies were large. If you look into the numbers, most of them were 20 to 30 patients in each arm. So that's the problem, a recurrent problem that you will notice in all these studies, or all these meta-analysis, in that the studies have really small numbers. So even though a particular study may show difference, when you look at the meta-analysis, you do not find a difference. And if you look at the papers that are selected for the meta-analysis, you can see the authors try to scale back the expectations, and they have to include, just for the sake of including some papers, they have to include papers that you strictly would not include in the Cochrane database criteria, for example. So again, in this study, they showed that there was absolutely no difference between antagonist protocol versus either a long protocol or a microdose flare protocol. So that echoes the Sankara study in that the conventional protocols are really not that useful, or there is no differentiation between one and the other, and you do not have a guideline to go by. And that was essentially echoed by the British Fertility Society's statement last year, that there's a lack of evidence to support agonist versus antagonist protocol in poor responders. They do state that there's some evidence in favor of LH supplementation in women over 35 years with poor ovarian response. I originally was going to talk about that in detail, and I have quite a few slides, and then because of the length of my presentation, I cut it short. With the amount of discussion that has gone on since yesterday morning at this Congress, I felt that I should include it, and last night put the slides back in again. But I'm not sure if I'll have the time to discuss that, but I'll be more than happy to discuss with any of you later on if I don't have time to discuss at this particular presentation. So the conclusion is that between the conventional IVF protocols, there's no particular protocol that can be chosen over the other. So whatever you're comfortable with, you're probably better off using that for your patients. What about the unconventional protocols? Here's a latest study by Mariam Eftekhar from Iran. Nicely conducted study, 120 patients randomized into two arms, one with microdose flare and the other with what they call ultra-short antagonists. 3 days of microdose followed by FSH and then antagonist at a fixed date. So they don't show a significant difference in the pregnancy rates either, even though there's 10 and 13. Statistically, that was not significant. And looking at the last decade of publications on natural cycle modifications, there are 5 studies, all non-randomized. The success rate was between 0 and 14%. Just as I mentioned earlier, that's the number to stick in your brain to tell your patients in terms of their prognosis. This is in comparison to Pelling et al., who performed natural cycle modification protocols on good prognosis patients whose pregnancy rate was only 8.3%. So essentially, it doesn't seem to make a difference what protocol you're following. And in terms of natural cycle with flexible GnRH antagonist and HMG, the latest study in June last month, 111 patients with Bologna Criteria decreased ovarian reserve. IVF cycle was performed within 3 months of them being diagnosed as poor ovarian responders, and the live birth rate was depressingly low at less than 1% in these patients. And using natural cycle with early SCG was a novel concept that the Montreal group have come up with. Bear in mind, these people have been doing IVM for a decade. And based on their observation that some patients, even with less than 10 millimeter lead follicle upon administration of HCG, have mature follicles retrieved. They took this one patient and at a lead follicle of 10 millimeters, gave HCG, retrieved 3 mature oocytes, 2 embryos were transferred on day 2, and she was pregnant and delivered with twins. That is one swallow summer does not make stories, so maybe there is some hope in doing that for patients, but I don't think that is ready for prime time yet. And in terms of aromatase inhibitors, using aromatase inhibitors to try and get the follicles to line up, There's this meta-analysis from Song et al., 3 trials, 688 cycles compared with microdose protocol. The clinical pregnancy rate was actually significantly reduced in these patients. And all the aromatase inhibitors studies, unfortunately, echo that. Either there's no difference or actually it might be detrimental. So aromatase inhibitors are probably not the best way to go for your pro-responders. How about clomid and letrozole? Here's one study, retrospective, where they obviously mixed their protocols at various times in the past from 2004 to 2009. And again, what they showed was the live birth rate was not significant in all age groups, as well as in greater than 37 years of age group. So the bottom line is, unfortunately, using either clomid or aromatase inhibitors, just letrozole, are not going to be useful for your poor responder patients. This is a small study I included only because it is the latest study that came out with only 66 cycles and 13 women. Although they say 30%, and at the first blush it looks very promising, if you look at per cycle, that is a poor response rate. So there are 2 studies that have been recently published that probably hold us some hope. So one is Delayed Start by Chakmak et al., and the other is the Crash Protocol. That's not so quite so new, but probably holds some hope. So 30 patients with poor response to estrogen priming, that is their established protocol. They prime their women with estrogen in the luteal phase and then do an antagonist protocol. And when they failed, these patients were then estrogen primed in the following cycle, followed by antagonist only for 7 days before even starting the FSH. 21 out of 30 patients went to oocyte retrieval, and out of those, 11 actually did not, only 11 went to oocyte retrieval in the past cycle. So that is a significant improvement in going to retrieval, and the clinical pregnancy rate was 23%, which is not bad at all. Unfortunately, we don't have any other studies to back this up. So the Crash protocol is similar to what Chakmak and Rosen did, in that you give 3 milligrams of cetrotide in the luteal phase, ostensibly to cause luteal lysis, but also you line up all the follicles and bring them all into sync. At least that's the theory. And what they showed in these patients, poor responder patients, was a 38% pregnancy rate per transfer. So I couldn't figure out what the pregnancy rate was per patient. So in conclusion, there's currently weak evidence that any of these protocols increase the chance of pregnancy in poor responders. So keep your eyes peeled for the Crash protocol as well as for the Delayed Start protocols. They may have some promise, but more studies need to be performed before we can hold any hope. So the importance of LH, I'm going to skip because I am running out of time. But I must say, my conclusion is that the addition of LH does not seem to be important in poor responders at all. Whatever it might be for other patients, certainly for poor responders, it doesn't seem to hold any hope. Finally, are there any adjuvants that may be of benefit? Of course, growth hormone and testosterone, as well as DHEA supplements are important, and the speakers following me are going to talk about that. So I'm not really going to touch upon that, but I would like to sort of touch upon estradiol. You may argue whether that is an adjuvant or is it part of the treatment protocol. I would like to think of that as an adjuvant. 8 studies were compared in this meta-analysis. 468 luteal estradiol only cycles versus 621 non-luteal estradiol. Only one of these studies was a randomized controlled trial, and the size of that is only 28 patients. The clinical pregnancy rate was 1.33 and barely significant at confidence interval of 1.02 to 1.72. So perhaps the estrogen does have a role. But then if you look at Mitch Rosen's study that I just presented, that they had 11 out of 30 patients going for retrieval using just the estrogen priming protocol. So I don't think estrogen only has any benefit. Perhaps use of GnRH antagonists immediately after the estrogen really lines up the follicles and helps you get a better retrieval and success rate. So they may have a gold mine in that. That's my cue to wrap up the. So testosterone as well as DHEA, I'll let my co-speakers allude to that. One thing I know, some people use follicular flushing to try and get more follicles out. This study clearly has proven it is not, if anything, it is detrimental to do follicular flushing. Therefore, I would advise you against that. And in terms of future directions, there's one study about transvaginal ovarian trauma actually increasing your success rate, which is funny, because endometrial trauma resulting in better implantation rate is now old news. We have transvaginal ovarian trauma potentially improving the outcome is the new one. So they have a very nice theory behind why they think that it might be helpful. And this is based on their observation clinically that patients who go for immediate cycling after a failed cycle do better than others who wait before they cycle. So we'll have to wait and see whether that holds any promise and whether the patients who fail should be immediately put through a second cycle. So in conclusion, I would not peg AMH as the only criteria to dash the hope of our patients. Perhaps the less than 0.1 is daunting to look at, but even these patients, some of them do get pregnant. The criteria for poor ovarian response is very loose, so even as we read these papers that are sure to come in the coming years, we have to bear that in mind and realize that it is fairly heterogeneous. None of the protocols, both conventional as well as unconventional protocols, seem to be particularly more useful than the other. However, the delayed start protocol from San Francisco probably holds some hope. And in terms of adjuvants, I will again hold my fort and not steal the thunder from my following speakers. But they may be of benefit, maybe. And in terms of future directions, I don't see a lot out there, unfortunately, at this point in time. With that, I thank you for your attention.
Thank you very much. Very comprehensive overview.
Thank you.
It seems that it's more successful to change the patient rather than change the protocol. However, I apologize for being a little bit late and coming after you started the lecture, but I'm referring to the JCEM publication of Mount Sinai Group in New York, Norbert Gleicher and colleagues, who had a significant difference in the outcome between those poor responders with high FSH in the high AMH or low AMH. So you might have mentioned that study.
Yes.
But my question is, in your experience, what proportion of the poor responders with high FSH do have normal or high AMH?
That's a good question. I don't know what proportion, but certainly there are discrepancies we come across. I cannot tell you, off the top of my head, I've not thought about it that way, but we do come across patients who seem to have high FSH baseline, and then you look at the AMH and say, wow, that doesn't jive, this doesn't make sense. So you do find those patients, and I find in those patients the FSH is to be discarded and disregarded. You have to go with the AMH and certainly put your eggs in that basket, literally speaking. But in terms of the study from Cornell, it is included in the, I showed meta-analysis. I try not to go into individual papers as much as possible, except for the last 2 years. And I find, for example, Schoolcraft in 1997 showed a 47% with growth hormone. And even with growth hormone coming into big hope today, I don't find that much of a significant difference in my patient population
There
using
is an
growth
answer
hormone,
to that.
Okay, I'll
which
have
is
to-
very telling. I mean, I have, I don't know. Schoolcraft has these wonderful, wonderful success rates, but in practice, most of us are struggling to emulate that success.
The problem with growth hormone is that many are including every poor responder in the growth hormone study. And it's a mistake because only those who have diminished endogenous growth hormone reserve tested by the clonidine test are going to benefit from the addition of growth hormone. Those who are clonidine positive, meaning that they have enough growth hormone reserve, they're not going to gain anything. And of course, those studies that include those patients don't see any difference and any benefit.
Good point. But, in Schoolcraft study, he did not do those
I'll
tests,
have
but he
to
still had great.
close.
It has been published by our group about 15 years ago.
Thank you
I'm
very
sorry, I
much.
did not mention that.
Thank you
Thank
very
you.
much for your contribution. Thank you so much.